There are actually two types of cardiomyopathy in which there is enlargement of the heart. One is dilated cardiomyopathy and other is hypertrophic cardiomyopathy. As the name indicates hypertrophic, there is hypertrophy of myocardium in hypertrophic cardiomyopathy, and as a result the wall it thickens and the cavity inside it actually becomes smaller. Whereas in case of dilated cardiomyopathy, the walls they may become thin or they may be normal, but the cavity inside it actually increases in size. So as a result of these differences, there is systolic dysfunction in case of dilated cardiomyopathy and diastolic dysfunction in case of hypertrophic cardiomyopathy. So dilated cardiomyopathy, there is progressive cardiac dilation and contractile dysfunction. Most commonly, it is idiopathic. There are familial causes and acquired causes. We will discuss them a little bit later, but first, let's discuss the morphology. So, on gross inspection, you will see an enlarged heart, and there are mural thrombi that are present, and valvular and vascular lesion, it most commonly is absent. Now, the histological picture. The histological picture, it most commonly varies depending on the cause, but mostly the myocytes, there can be hypertrophy and enlarged nuclei, or there is attenuated, stressed and irregular myocytes that are present. Next, we have interstitial and endocardial fibrosis, and there are scattered areas of replacement fibrosis, and these replacement fibrosis they result as a result of hypoperfusion or some missed myocarditis. In DCM, that is caused by iron overload, there is intramyocardial hemosiderin accumulation, and that is visible by staining with Prussian blue. As I have told earlier, that there is contractile dysfunction, so the ejection fraction will be less than 25%. There can be mitral regurgitation because, as I told earlier, that the cavity is actually increasing in size, so the mitral valve is not able to close properly, and there is mitral regurgitation. Abnormal cardiac rhythms, they can occur, yes. I have told earlier that there is thrombus formation, and a part of thrombus can break down and result in the formation of embolus. Most commonly, the age of presentation is 20 to 50 years. And these are the features of left-sided heart failure. There can be raised JVP, and S3 and S4 heart sound may be present. In order to make the diagnosis, we will do the following investigations. Number 1 is chest X-ray, second ECG, third echocardiography, and then we will move towards cardiac MRI or genetic testing. Now the causes. Number 1, we have the genetic causes, and most commonly there is single gene mutation, and the pattern of inheritance is autosomal dominant mostly. So the genes for those proteins mostly include the proteins that are alpha cardiac actin. These are the proteins that actually interact with sarcomere on one side and the cytoskeleton on the other side. And we have genes for the dystrophin protein, desmin and nuclear laminin protein. Then we have mitochondrial energy producing proteins that are affected, and the genes that share their origin with the conduction system, they can also be affected. And as a result of these mutations, there is dilated cardiomyopathy. Next, infection. Actually, we have found that there is nucleic acid of the Coxsackie B virus in the affected patients. So we have concluded that infections can be a cause of dilated cardiomyopathy. Similarly, we have found antiviral antibody titers in some patients, and so we can conclude that a patient may be affected by a virus, and as a result of that virus there is myocarditis that may be missed, and there are formation of antiviral antibodies in that patient, and later on he presents with dilated cardiomyopathy. But by measuring these, we have concluded that it can be a cause of dilated cardiomyopathy. Next, we know that there are metabolites that can cause dilated cardiomyopathy. Here we have alcohol and its metabolite. In case of chronic alcoholism, there is thiamine deficiency, and it results in beriberi disease. And we know that Dilated cardiomyopathy occurs in case of beriberi disease. Similarly, cobalt and doxorubicin. It is a very important cause of dilated cardiomyopathy. Next, we have peripartum cardiomyopathy, and it is multifactorial. Here, the cause can be pregnancy-induced hypertension that occurs in some patients. Similarly, fluid overload, nutritional deficiency, gestational diabetes, and immunologic processes. They can cause dilated cardiomyopathy. Similarly, impaired angiogenesis, and it can also be a cause of dilated cardiomyopathy. Next, iron overload. Mostly, iron overload causes dilated cardiomyopathy, but it can also cause restrictive cardiomyopathy, and it's also a type of restrictive cardiomyopathy is also a type of cardiomyopathy, and we will discuss it in coming videos. But here, it is the most common cause of DCM, and it can result from multiple transfusions and genetic disease, that is hemochromatosis. And here we have iron mediated reactive oxygen species, and it also interferes with the metal dependent enzyme system. So that's all about the dilated cardiomyopathy. If you like this video, click on the like button and also subscribe to the channel. Thank you so much for watching this video.